Good morning, good afternoon. It's great to see such a national presence. I have a broad-based practice in California and Nevada, including Reno, Fresno, other places where I work. So it's great to see some familiar names and faces here. So the reason we're talking about core antibody is because there's a lot of confusion, I would even say fake news about this testing and some misinformation that's been carried forward over the last 2 decades. So I'd like to correct that with you all today and ask you to help me carry this message to the general community. And if you hear some of the old information or misinformation, if you would do your best to correct that. It's really great for communication, education, security. And let's go to the first slide. So I think you all are familiar with the epidemiology of hepatitis B. Globally, surface antigen positive is 292 million people. And we just had a paper published in Hepatology last week, myself, Robert Wong, Carol Brogart, and others, where we said up to 2.4 million in the US are surface antigen positive. Very important numbers. Look back up to the first bullet. We will say that there are 2 billion people who have been exposed to hepatitis B as defined by core antibody. Now, core antibody is a very interesting antibody because once a person's infected, they tend to have core antibody the rest of their life. And we've often wondered why that was. But we know hepatitis B is incurable. This is a DNA virus. It has a CCC DNA intermediate that lives inside the nucleus of the liver cell, and it also integrates into the genome, although the integrants typically only produce a truncated surface antigen. So in an ideal world, you get rid of all the B from the liver cell, you get rid of all the CCC DNA, the liver cell could keep producing surface antigen in this future position if we can actually get there. So I want you to keep in mind that right now, person gets infected with hepatitis B, the chance of their body clearing every molecule of hepatitis B from their liver is far less than 1%. So this is a chronic disease, and some of those patients are defined as having chronic hepatitis because they're surface antigen positive. But as long as core antibody is present, this indicates that CCC DNA is present, and the CCC DNA is making a core antigen. That's why we have core antibody indefinitely, because the CCC DNA is making very low levels of core, and that's stimulating B cells to make antibody. So we're going to go over this from, kind of look at this elephant from different sides. Next slide, please. So when you order hepatitis B, you have to be very careful because I still see every week when I'm evaluating new patients, they come in with a hepatitis panel that includes core antibody IgM very commonly. They don't test surface antibody because this is an acute hepatitis panel. So it's hepatitis A IgM, hepatitis B core IgM, hepatitis B surface antigen, of course, and hepatitis C antibody. But this is rare to see acute hepatitis, viral hepatitis. I know it is seen, but you need to order that acute panel in the correct clinical setting. Otherwise, you're going to order total hepatitis A antibody, you're going to order this hepatitis B triple panel, and you're going to order hepatitis C antibody. Of course, you want to know A, not because it's chronic, but because we need vaccine. It's a vaccine preventable disease. To know hepatitis B, you have to have all 3 of these tests. You will be lost if you only order 2. Fortunately, most organizations are making this more simple. If you look back at the CDC website 6, 8, 10 years ago, they said in this group you order 1 test, in this group you order 2 tests, and in some patients you order 3 tests. Well, many patients weren't getting any tests done, or they're getting the wrong test done, or unfortunately the wrong interpretation. So surface antigen infection, surface antigen positive, that equals active infection. I want to remind you that all patients who are surface antigen positive need to be checked for delta hepatitis, and that first test for delta hepatitis is an antibody test as well. Core antibody, just think of one word, exposure. But if you're exposed to an incurable virus, exposure equals persistent cccDNA. Surface antibody indicates immunity only if core is negative. There is no natural immunity to hepatitis B. You will see that in hundreds of articles, but this is an oxymoron. This does not exist. But if you have surface antibody and core antibody together, we have a new term that we use, immune control. So the higher the surface antibody level naturally after clearing surface antigen, the better the immune control. But I want to highlight here that in many recommendations, including AASLD guidelines, based on zero data, people recommend boosting people who are core antibody positive only, trying to elicit a surface antibody response. But there is no clinical benefit. This is costly because you have to pay for 1, 2, or 3 doses of vaccine. You have to bring the patient back, you check surface antibody levels, but it doesn't mean anything. It doesn't mean any type of protection. In fact, vaccine-induced surface antibody in a patient who's core positive doesn't impart a broad-based immune control that you get with natural infection. So if you see a patient who's core antibody positive only, you have to think about 3 things. Do you evaluate them for OBI, occult hepatitis B? The answer is yes, if they're going to be immune suppressed. The answer is yes, if they have elevated liver enzymes. Because in those core antibody positive patients, you're going to find hepatitis B DNA in their blood in somewhere around 7 to 15% of patients. And this is because we have very sensitive hepatitis B assays today that go down as low as 7 international units. That's really 7 viruses per milliliter. So think about occult hepatitis B in core antibody alone. The next thing you have to think about in core only is reactivation risk. This has been seen with the hepatitis C DAAs, which is interesting because those drugs don't modulate the immune system directly, but very much an important issue if you're giving that patient or the patient's being treated with prednisone or rituximab, Imuran, TNF inhibitors. There's a gradient of reactivation risk that I believe is best covered in a paper I helped co-author with Raj Reddy from Penn that is published in 2015 in Gastroenterology. It goes over the gradient risk of these different immunosuppressive agents in this setting of hepatitis B core antibody positive. Now, somebody who's core plus surface antibody positive is much more protected from reactivation because of this immune control. And remember the third point I mentioned, no vaccine boosting. You might feel better, but the patient is not benefited by this vaccine effect, even though the surface antibody may become measurable or may increase. So this is really the most important slide of this presentation today. And I look forward to discussing this further with everybody. Next slide, please. I'm going to pick up the pace just a little bit now because we've done the deep dive. So remember, hepatitis B is a DNA virus similar to Epstein-Barr, CMV, different herpes viruses. These are all viruses that remain in our body lifelong. Therefore, there's no natural immunity. There is immune control. I want to highlight here the 4th bullet. The false positive rate for core antibody is 2 per 1,000. This number was established through some pretty elaborate research done by Abbott and also later Roche with their Alexa system in about 2002. And he did some very interesting things, developing different types of core antigen, measuring different types of core antibody, looking for OBI, risk. Is it a true positive? Is it a false positive? So they refined this test 20 years ago. And the false positive rate is so low, we don't really discuss false positives anymore, even though that false positive misinformation have been carried forward for the last 2 decades. I've been working very hard with a number of other individuals, including, very importantly, the CDC, to fix this fake news, that this is not factual. This is not a test with a high or even a concerning false positive rate. Next slide, please. This is very interesting because liver donors are people who potentially have some type of risk because they're in a car accident or a gunshot wound or a stroke. You're going to find core antibody positive also in a general population with very similar numbers to this. So this is anti-core positive alone or anti-core plus anti-surface. Core meaning the same thing, exposure. So 5 to 6% of US population is core positive right now today. Now, if they're surface antibody negative, core antibody negative, surface antigen negative, this is where we need to have vaccine. But look in China, Taiwan, and this is very representative of Southeast Asia also. There's a huge number of patients who've been exposed to hepatitis B, cleared surface antigen. But in these types of countries, you would not do broad-based hepatitis B vaccination without pre-test, doing your triple panel, because you're going to waste a lot of money because 60% of the population doesn't need vaccine. And of course, 5, 6, 7% are surface antigen positive. They need to know their surface antigen status and be linked to care. So this is a very interesting discussion because today there's a CDC dialogue with the ACIP about vaccination, with the Preventative Health Services Task Force about testing for hepatitis B. Should it be risk-based testing, which is what they advise now, versus test everybody, which is what the Hepatitis B Foundation advises. We think it's a very simple message. You test all adults for the triple panel to figure out who's got core, who's got surface antigen, who needs vaccine, the deal's done. Risk-based testing, unfortunately, is discriminatory, it's stigmatizing, and it fails. So I'd like you all to be thinking about that in your practice, in your advocacy. Next slide, please. So I've already covered this issue. I just want to repeat that giving somebody vaccine who's core positive gives them a false sense of protection. It gives them a sense that they have the vaccine, they can't get hepatitis B, they don't have hepatitis B, yet they're still at risk for reactivation. Next slide, please. So just to reiterate this just for a second, surface antibody positive, core antibody positive is immune control. There is a clinical setting where you'll find surface antibody positive, core positive, and surface antigen positive. In that setting, the surface antibody doesn't mean much because the surface antigen dominates. A person could be infected with different variants, different serotypes, one serotype eliciting an antibody, the surface antigen, different serotype, not binding the antibody's not neutralizing in some way. But that surface antibody is not important. It's the surface antigen positivity that counts. Now, if you think somebody might be clearing hepatitis B, you can quantitate surface antigen, very importantly. And that surface antigen quantification could be a subject of another presentation through this ECHO that I would propose. There is one more comment. If somebody has really high natural surface antibody titers with core antibody being positive, they have more protection from reactivation. So someone getting chemo, say rituximab, who's core positive, whose surface antibodies over 1,000, is much less likely to reactivate with rituximab compared to somebody whose surface antibodies barely detectable at say 15 or 20. And there are cases where the surface antibody titers slowly decline. Core antibody, of course, is a yes, no. We don't quantitate that. But as the surface antibody levels decline in the presence of core, their risk for reactivation actually increases. Next slide, please. This is just some data on rituximab, which is probably the worst actor. There's also people getting stem cell transplant who have various forms of preparation for that, also high risk. Adriamycin, commonly given for breast cancer and other types of cancer, is a true chemotherapy, has a risk for reactivation. Interestingly, there's a new group of drugs called checkpoint inhibitors. You've all heard about this, PD-1, PD-L1, CTLA-4. These drugs really activate the immune system, but interestingly, they've been associated with hepatitis B reactivation as well. So basically, any medicine that modulates the immune system one direction or the other, or hepatitis C, DAAs, has a risk. Next slide, please. This is just more about surface antibody being protective, just some interesting data. Next slide, please. And antibody testing to core, this just talks about what the cutoff are. There's a signal to CO that's here. They have an arbitrary cutoff that's been established through large testing of both high risk and low risk patients. Next slide, please. And this is the Architect Anti-Core 2, and just talking about how reliable these tests are, coefficient of variation, standard deviation, the number of patients that were looked at with negative and positive controls in different plasma panels. So very robust. And down in the specificity section at the bottom, this goes back to the whole issue about a false positive rate being very, very low. And I looked across not just this package insert, but a number of different studies. And that's why I came up with that number, false positive rate of 2 per 1,000. These are very specific tests. Next slide, please. Sensitivity also is very good. All hepatitis B virus makes core antigen, and therefore almost every patient, unless they're profoundly suppressed, will be making core antibody. Next slide, please. And this is one issue that's quite interesting, is that if you had access to core antibody titers and somebody comes into a blood bank and they're core positive, the blood bank would actually get the titer or the level of the core antibody. And if the core antibody was just above the upper limits of their cutoff, which is 1.0 here, they might call that person back if they answered negative or no to all the different risk questions on the questionnaire. And if they come back and their core antibody titer is undetectable the next time, they may be able to re-enter the donor pool. This is really a blood bank-based issue, not something that's applicable to all of us in our clinic. In our clinic setting, people have risks. They are from an immigrant population. They have risk behavior. They have hepatitis C. They've got other behaviors that make them at risk or put them at risk for viral hepatitis. Therefore, you need to believe that core test to be a true positive. Next slide, please. And the core antibody tests are quite comparable. In the AASLD guidelines, they talk about certain tests that are used internationally that had a much higher false positive rate. That data is over 2 decades old. Currently, almost every country that I have visited, I've been in 54 different countries so far, and I had the chance to speak to hepatologists, blood bank specialists, epi people. And most individuals are using these very standardized tests from Abbott, Diasorin, from Roche. There's a variety of different companies in this space. Next slide. And they're very, very reliable. So when they measure core antigen, they're using this serotype called AYW. There's a number of different serotypes. These are just slightly different proteins that the hepatitis B virus makes for surface antigen. The core antigen is even more stable in terms of that core structure, the proteins, the amino acids that are presented. So they use well-characterized serum specimens. They have these signal to cutoff levels. And if you really want one more test to look at exposure, you can actually get another antibody test called anti-HBe. Almost all these patients who are core antibody positive, especially if their risk was less than 20 years in the past, are going to be anti-E positive as well. E antigen is a antigen that's a modification of the core antigen, and it's also produced off the cccDNA. Next slide, please. I think we're almost at a wrap up. Core antigen, IgM, anti-HB core IgM antibody appears very, very early. But if somebody's immune compromised, immune suppressed, that core IgM rise may be delayed, and you may wish to repeat that, or just move directly to HBV DNA testing. If somebody in front of you has got acute hepatitis, picture looks like viral hepatitis, and you need to do second level testing. Next slide, please. We talked about surface antibody core. So if you look at across a large population, 100 people who are core antibody positive, 94% are going to be surface antibody positive. Only 6% are going to be core only. So six is a really nice number. 6% of the US population is core antibody positive. 6% of 6% are core alone. So it's a relatively low number, but it's likely you're going to see these people in your clinic because so many people are getting hepatitis B testing now. Next slide, please. And then this just talks about measuring HBV DNA in people who are core only. These are some interesting populations, patients who have had brain death, but are organ donors, cornea donors. And this is where I come up with this number. About 6%, 7% of people who are core only will have circulating measurable HBV DNA. Next slide. I think we're almost done. This is on occult hepatitis B. Next slide, please. And we covered this. Next slide, please. And surface antibody titers we talked about. You can look at these. The higher the titer, the better the protection. Next slide, please. And we discussed this. Next slide. Slides can be shared. Next slide. We've really gone over all this already. I'll leave this as the final slide, Catherine, so we can wrap this up. This is a grid that Ben Tran and I and the Asia Pacific Health Foundation in San Diego established. It really talks about these different profiles of the 3 different tests, what action you need to take, what interpretation you need to summarize. This would be a good thing to print out or carry someplace with you. Catherine, I think that's a wrap. We can move to the presentation if you like. Thank you.
Great. So we'll open it up for a couple of questions. If anybody has questions for Dr. Gish, feel free to ask them. You can unmute yourself. Just introduce yourself if you do have questions.
Hey, it's John Finkel. I wanted to ask a quick question of you. How do you approach patients who were Hep B core antibody positive before liver transplant and then receive a liver that's Hep B core negative? Do you offer those patients prophylaxis still or not?
That's a great question, John. So you're taking out the liver of that core positive patient, and most of the hepatitis B in your body is 99.99 is sitting in the liver. There's only a few sites extrahepatic where there may be residual hepatitis B virus. So one thing to think about is checking an HBV DNA. They're positive. That means they probably have substantial virus, even at the time of transplant, which may be circulating, could reinfect that new graft. And then you would want to put them on long-term antiviral therapy. They're core alone, HBV DNA negative. I would monitor those people, just tell them there's a risk of reactivation. And if their liver tests increase, you do your triple panel, you do your DNA, and then decide on nuke therapies at that time. That, I think, is a cost-effective and safe approach. What are you thinking, John? What's your protocol?
That's what we used to do. And then I want to say 2 years ago, we had a patient in this scenario who had actually had 2 liver transplants, both of which were core negative. and she ended up having a Hep B occult infection following treatment for PTLD with rituximab. And so, she got put back on antivirals, has been fine, but it kind of raised this question in our program: what should we do with these patients? And I think lately we've been erring on the side of prophylaxing them, but I feel like we're over-treating. So I was curious what everybody else was doing.
It's a great point, and sometimes we run our life by anecdotes as opposed to data.
Thank you.
Any other questions or comments about anything? All right.
Hi, thank you very much.
Go
Thank
ahead.
you very much for your presentation, sir. It's a lot of information for someone like myself. I feel like, admittedly, I am a newbie to this. So I have patients that I've been surveilling for hepatitis B. And just to make sure that I understand what you presented correctly, if they have been core positive, that's going to persist, obviously, because they're making DNA. cccDNA is making core antigen. If they have surface antigen, they have an active infection, and then check for Delta. Can you expound? I have a 2-part question. I just want to be sure I understand what Delta is. Is this the genotype you're referring to? Or, and then the other thing is, I have specific patients that I'm curious about, and maybe I'll touch base with Catherine I can consult with somebody locally just to be certain.
Of course. And, one other thing too, is if you have a case, you can present it here and we can provide recommendations and talk through it with you. It's okay to not know what to do with them, and we'll work through that together. So I just want to echo that. And another thing too, to address your first part, we are going to be talking about a Delta co-infection today. So you'll kind of get a case experience with that. But Dr. Gish, I'm sure you may want to respond as well.
It was a great question, Myra. The D is for deadly. Delta is an RNA virus that piggybacks on hepatitis B. There are 11 different genotypes of hepatitis B, and one of those is genotype D. So it's a great question. Genotype D is very prevalent in the Mediterranean, Central, East Asia, and the Indian subcontinent region. So this is a little bit confusing with this alphabet soup we have here. So genotyping of hepatitis B is rare. I used to do it all the time. Now it's not of much utility. And of course, there's other mutants of hepatitis B. One are called core and pre-core mutants, which we could discuss at a future event also. But this is a simple, what I'd like to see is reflex testing. Although we've had a big problem, Catherine and I've been working on, is getting LabCorp even to test for Delta. I just looked, Catherine, today on the LabCorp website. They still don't have Delta antibody listed anywhere. So we've got to fire up some missiles, and I shouldn't use the word missile after North Korea this week. Fire up some engines and get LabCorp, moving. So Myra, we'll talk about Delta hepatitis, D for deadly in the case.
I actually do have a patient where I was looking at her lab results today, right before we got on the call, and I sent her for labs. Surface was non-reactive. The core was positive back in December, and I treated her for Hep C, and I did some additional labs because I was concerned. Just recently, she came back again, core positive, obviously, IgM negative, but it reflexed for genotype D, and it looks like a viral load of 630 with a log of 2.79.
So this is a occult hepatitis B if the surface antigens remain negative. And then you said reflex to D, that's genotype D or
Yeah,
Delta?
it said genotype D as in David.
Okay. That's a strange reflex test. I'm surprised they went that deep, but genotype D is prevalent. It's not going to help you much, but this is really OBI, so it's replicating, and you have to decide whether you're going to treat that hepatitis B or not. So that's a special case that would need to be looked at in more detail.
Mm-hmm. I was thinking I should refer her for someone who specializes, but I definitely would like to learn more about it, because I actually saw her in the office. She is now pretty much undetectable for Hep C, but I did a physical exam on her just yesterday, and her abdomen did feel like she might have had her fibro score was negative, no cirrhosis, but she did definitely feel questionable to me. So
Hepatology consult, Myra, is the best idea here. Great
okay.
idea.
Mhm.
And
Thank.
And Myra, we're happy to help you with that if you need assistance with, and one of our providers on the line here might be able to help with that as well.
Yeah, I'm thinking I'm going to reach out to you, Dr. Finkel.
Dr. Finkel, are you ready?
We're glad you're here, John.
Perfect. Great. I'm glad that we're able to make that. And Myra, too, that's a case that we can bring to the table for another session, too. If you're interested in presenting a case, I think that'd be really great.
Yes, I have two, so I'll be glad to send them to you and we'll discuss.
Awesome. Thank you. And just in the interest of time, I'm going to transition everything over to the case presentation now. So I'm going to open it up for OU to present the case. I'm going to share the case